Alright guys, welcome back. So in this video we're going to look at part 2 of Perio board exam questions, and I wanted to start by letting you know where I'm getting my questions from. So we're all familiar with this book. This is like our Bible when we were in dental hygiene school. It's the Darby and Walsh Dental Hygiene Theory and Practice textbook, our Bible. The place where I'm getting my questions from is Darby's Comprehensive Review of Dental Hygiene textbook. So it is a review of everything, or almost everything, listed in that textbook. And what I really like about this compared to other resources that are out there, I like Darby's and I like Mosby's, is because it's evidence-based. They reference all their information. There's no spelling mistakes. Everything is referenced. And that's what we tell you in dental hygiene program, right? That you guys do a course on research, that everything must be backed up by research. Everything must be backed up by evidence. And this book does that. So let's start with our first question. The hygienist notes the following clinical signs during the periodontal assessment of a young male teenager: moderate plaque, gingival redness and tenderness, BOP, gingival margin slightly coronal to CEJ, probing depths of 2 to 3 millimeters, and an inflammatory response that seems appropriate given the amount of plaque biofilm. What this phrase means here is that given that there is moderate plaque, the inflammation that we see, the redness and the bleeding we see, it makes sense. This is important to know because I'm going to have another question where this will be reworded in a different way. So that's why I want to highlight this, because when you see the next question, it'll make more sense. Okay, so the question is, which of the following types of periodontal disease should the hygienist suspect for this patient? And you can see there's a list of answers here. So I'll get you to pause the video so that you can decide or let me know what you think the answer is. So the answer to this is A. And let's see how we came up with this answer. So is gingivitis associated with dental plaque only? Now we know that this person is a young male teenager, and typically at this age, the young male teenager, they go through puberty. So why is it not puberty? I'll answer that in a bit. I'm going to look at option D, where it says oral contraceptive associated gingivitis. So oral contraceptive is, birth control pills. A guy would not be taking a birth control pill. So that is not an option. When you look at C, gingival disease associated with endocrine system and fluctuations in sex hormones, it's a vague category. When you say sex hormones, are we, is the question referring to puberty? Is the question referring to the menstrual cycle, pregnancy? If it's not specific enough. This one, puberty associated gingivitis, is more specific enough. So I like that answer better than the C. The answer in C. So I'm going to cross that out. It's too wordy. It's not really a classification per se because it's vague. We like something more specific. Now, why is it gingivitis and not puberty associated gingivitis? Because this guy is going through puberty. Well, I'm going to show you the next question, and then we're going to go back and compare the answers. So let's look at this question. The hygienist notes the following clinical signs during the periodontal assessment of a young male teenager. So again, a young male teenager typically goes through puberty at this age. But here we see slight plaque biofilm, not moderate, like the previous question, slight. We still see gingival redness and tenderness. We still see bleeding on probing. Probing depths are 2 to 3 millimeters, so it's not perio, because if it's 4 millimeters, we get a little concerned. And then it says an inflammatory response that seems inappropriate given the amount of plaque biofilm. What that means is that this guy, this young male teenager, has slight plaque. And so with slight plaque, why are we seeing so much redness and tenderness? Why is he complaining about that when he's got very little plaque? Why is there so much bleeding? Or not so much, I shouldn't say the percentage, but why is there bleeding on probing when he's got very, very little plaque? He's got an inflammatory response that doesn't seem right, given that someone who has slight plaque biofilm should have very little redness, very little BOP. And so the fact that it's saying it's inappropriate, it doesn't make sense, that's a red flag right there. When you have a question worded like this, what would you think would the best answer be? We already said it can't be D because a guy does not take oral contraceptive birth control pills. We already said that it's not C because it's too vague, right? Is the sex hormones referring to puberty? Is the sex hormones referring to menstrual cycle, menopause? Like, what is it? It's too vague. So it's either A or B. In this case, the answer is B. And the reason why the answer is B is because it's the puberty, it's the hormones, it's the sex hormones that's causing the redness, that's causing the bleeding. It's the sex hormones, it's the hormones that's coming into play that's causing an inflammatory response. Typically, when you see a young male teenager guy with slight plaque, we may not see as much redness. We may see BOP, but it's not like a significant amount of BOP. Now, I know it doesn't say the percentage here, but this statement over here just tells you that the inflammatory response, the redness, the bleeding that we see is not, something you would normally see with slight plaque biofilm. So given that it is not something that you normally see, the inflammatory response, the redness is not something you normally see with someone that has slight plaque biofilm. The reason for the inflammatory response in this case is because of puberty. So the puberty is causing the redness, the BOP, the tenderness. Whereas in this one, someone who has moderate plaque biofilm, it makes sense for someone who has moderate plaque biofilm to have redness, to have tenderness, to have bleeding on gentle probing. So what I'm trying to say here is that if there's no indication that this person is going through puberty at this time, just go with gingivitis associated with dental plaque only. And this is your key statement that tells you that this person had an inflammatory response that seems appropriate given the amount of plaque biofilm, because people with moderate plaque typically do have redness, typically bleed just on gentle probing. And so that's normal. But if there's a question where the inflammatory response to redness doesn't seem right, given that this person only has slight plaque biofilm, well, then you question yourself that, maybe it's not the plaque that's causing the redness, maybe it's his hormones that's causing the redness. Okay, let's look at the other question. Your assessment findings for a client include pink gingiva, moderate plaque biofilm, probing depths of 6 to 8 millimeters. How would you classify this disease status? So 6 to 8 millimeter is a red flag. It can be healthy. This person can't have healthy gums because of the deep probing depths. This person can't have gingivitis because of the deep probing depths, because anytime someone has 4 millimeter or more of probing depth, then we automatically got to stage them. So 6 to 8 millimeters. Let's look at this chart again. When you look at stage 2, 5 millimeters or more of probing depth makes someone stage 2. When you look at stage 3, 6 millimeter or more makes them stage 3. Stage 4 is if they have other severe factors, like they can't chew properly, they've got occlusal trauma, their bite, like their mouth is, the teeth are drifting or flaring. That would be stage 4. So stage 3 is when the probing depth is 6 millimeter or more, with no other factors listed over here. And so that's the answer over here. The answer over here is stage 3 because of their probing depths. Okay, let's actually look at this question right here. A patient calls the office complaining of gum pain. Okay, so remember, think of a classification, a periodontal disease classification where pain is involved. Okay, so if patient is saying they have gum pain, and when you do the perio assessment, you see tissue necrosis. You see a really very red gingiva with spontaneous bleeding. You go in there and it starts bleeding like crazy. Yellowish white tissue slough and sudden onset. So the answer for this is C. And when I see the word necrosis, I want you to link it to necrotizing, because you can see it's a similar thing. So necrosis is like flesh eating, like it's eating away the gums, it's eating away the papilla in this case. Necrotizing periodontal disease, that's the only type of periodontal disease where you would feel pain. And so right away, when I see this word gum pain, I'm like, okay, automatically it's probably necrotizing periodontal disease. Hemorrhagic periodontitis, that's like when there's a bleeding problem. It's not necessarily a classification that we have learned about in perio. periodontitis associated with leukemia. So with leukemia, you're not going to get tissue necrosis. You're not going to get yellowish white tissue slough. Periodontitis associated with PMN dysfunction. So this is another word for PMN is neutrophil. So which is a white blood cell. So when one of your white blood cells don't work effectively, you could get perio, and that's what this classification refers to. Again, it's not the best answer, because when I look at necrosis, immediately I'm thinking necrotizing periodontal disease. And so when you look at a picture of someone who has necrotizing periodontal disease, you can see that the papilla, there's necrosis, there's like the eating away of the papilla is gone. You can see the yellow-white slough, like that layer of tissue, which is a sign of necrotizing periodontal disease, and the client will be telling you that they're in a lot of pain. So that's those are the typical signs and symptoms that we see with people that have necrotizing periodontal disease. This used to be called, I'm going to write it down here, NUG if it was just gingivitis, so there was no bone loss, and NUP, necrotizing ulcerative periodontitis, if there is bone loss involved. Now it's just classified as necrotizing periodontal disease. Okay, let's look at a case study. So we're going to end off with a case study. Now this case study is quite long, so I'm going to get you to pause, and then what we're going to do is once you read the case study, I want you guys to tell me what are your red flags. This is what you should do when you read a case study. Read it carefully and then highlight your red flags. Highlight the ones that are the points that are really important to you. Okay, so when I read this case study, these are my red flags, and I'm going to highlight what stands out to me. So the first thing that stands out to me is the high blood pressure. When we look at normal blood pressure, because this is from the American Heart Association, normal blood pressure is, around 120 over 80. If it gets around 130 and higher and 80 and higher, we're starting to look at stage 1 or a beginning of prehypertension. Basically, the blood pressure is getting concerning now. And so when I look at this person's blood pressure, 134 over 88, 5 minutes later, it went up, 136. The systolic number went up, the diastolic went down, 86. So let's look at this. It's in this range over here. So high, right? Not high, but like pre-hypertension. So it's something I'm going to take a note of. When I look at the pulse, do you guys know what normal pulse is for an adult? Normal pulse for an adult is 60. 60 beats, actually 60 to 100. So is this a red flag? No, because their pulse is normal, right? Okay, so I actually shouldn't be highlighting that, because pulse of 78 is normal. Anywhere from 60 to 100 is good. If it's at 110, then I would be highlighting it. Okay, they have an overactive bladder, osteoarthritis, seasonal allergies. Okay, yep, that's good. But the one that really flags out to me is the diabetes, type 2 diabetic. This person is taking metformin. So she's taking metformin, hasn't really been following up because of financial problems. So she's not really taking her medications now. But last month when she took her HbA1c level, so this is not how how sometimes they poke themselves on the finger and then they get a reading. This HbA1c is not the one that you poke on the finger. This HbA1c is done via blood work. People who have diabetes go for blood work every so often where their HbA1c level is checked, and hers was 8.2%. That's kind of high. Anything more than 7% is high. Thankfully, this person is not a smoker, does not drink, or use drugs. When I look at the dental history, it's been a while since her last cleaning. So her last cleaning was 2 years ago. There is a lot of work that has been done, amalgams, composite, and quite a bit of extractions. And these are her wisdom teeth that were extracted. That makes sense. But you can see that there are 1, 2, 3, 4 teeth that have been extracted because of gum disease. So she's probably lost a lot of bone, which made the teeth very mobile, which resulted in extraction. So what is her chief complaint? Her chief complaint is that, actually, you know what I'm just going to do? I'm actually going to highlight this because this will come into play when we're staging and grading. Okay, my teeth are shifting and I am having trouble eating. I would like to replace the missing teeth with implants. Okay, so teeth are shifting, trouble eating. That's concerning. And we'll look at why that's concerning, because this tells you something for staging and grading. So this is really small. I really apologize for this. I'm going to see if I can make it a little bit bigger for you guys. What are we looking for here? Well, what I'm looking for here when I see this is I'm looking for the highest probing depth. So we see 5, 6, 7, 9. Okay, so I'm seeing 9 as my highest probing depth. Oops, that was not good. Okay, so I'm seeing 9 as my highest probing depth. I don't know why. Okay, ignore the 7. 9 is the highest probing depth. And then when I look at cal, because I also want to check for interdental cal, so cal in between the teeth, and I think my highest interdental cal in this on the max, oh my gosh, okay, is this one right here. So 10, quite high. Let's look at the MAND. Again, I'm looking for the highest probing depth number, so I see a 9 over here. Okay, so again, 9 is my highest probing depth overall. I'm looking for the worst area. And when I look at cal, the highest interdental cal, the highest cal in between the teeth is a 10. We do see a 12 on the facial and lingual. Right now I'm just looking at interdental in between, so 10 is the highest. Okay, let's keep that in mind, because when we look at staging, we need to keep in mind what the highest probing depth is, and we also need to look at cals as well. When we look at her images, so her intraoral photos, you can see that she does have indeed some missing or extracted teeth right here and right here, and we have a question on this, so I'm gonna come back to these photos later, but you can see that this is the missing area right here, and this tooth has, is supra-erupted. And if you look over here, there is no opposing tooth over here, hence this tooth is coming down more because there is no opposing teeth or a tooth on that side. We are looking at her radiographs. Look at her bone level. She does have significant bone loss over here. You can see that the teeth are drifting. So here it's drifting to the midline, like it's drifting. It's not straight up, right? It's kind of drifting this way and drifting this way. And you can see this tooth is quite up there. It's erupted, super erupted, and same with this one. Okay, so let's look at, here's the bite wings. So if you wanted to see, I'm gonna bring it back. You can see calculus spurs over here. So this is a challenging client to debride. So using the 2017 World Workshop on the classification of periodontal and peri-implant diseases and conditions, which is the best stage classification for this patient? Okay, here's the stage. When we looked at the cals, we said 10 millimeter was the highest interdental cal. So not 3 to 4, not 1 to 2, 10 millimeters was the highest. So I'm just going to circle this for now. Radiographic bone loss. If I show you the worst area over here, I'm going to look at the lower anteriors, and you can see that the bone level it should be over here. I'm trying to draw a line over here, but it's gone all the way up to here. And so it is beyond the middle or the midpoint, right? So if it's extending beyond the middle third of the root, then we're going to circle this one, because there's quite a significant amount of bone loss. Tooth loss. So remember, when we were looking at the case study, and I'll bring it back up over here, she has lost 1, 2, 3, 4 teeth because of gum disease. This is wisdom teeth. Wisdom teeth extraction does not fall into the staging, but extraction because of perio does fall into the staging. So we do take that into consideration. So 4 teeth, not 5 teeth, 4 teeth. And then, what was her chief complaint? Her chief complaint was that her teeth are shifting and she's got trouble eating. That is important, because when someone has trouble eating, so masticatory dysfunction, and the teeth are like drifting, it's a concern right there. So because I've circled this, this automatically puts this person into a stage 4, because you take the worst one and you automatically stage it based on the worst circle, so stage 4. In terms of probing depth, yes, definitely it is more than 6 millimeters. In fact, the highest one we saw was 9 millimeter. But what shifted them to a stage 4 is because she's got difficulty chewing or eating, and her teeth are shifting. That was her chief complaint. So the answer to this one is stage 4. What about grading? What is the best grading, or what is the best grade for this client? I know she doesn't smoke, but she did get her HbA1c level assessed, and it was more than 7. It was 8.2. So this I'm going to circle, which means that she is a grade C. Okay, and I mean, yes, we could also look at all these other factors as well, but just by looking at the grade modifier, I know that she is a grade C. So the answer to this question is grade C. So, which of the following is a grade modifier risk factor associated with the case? Select all that apply. Remember her HbA1c level, which was 8.2, so that is a very prominent thing to take note of, because it is a grade modifier risk. She does not smoke, she told us that. Poor plaque control, I mean, yeah, she does have poor plaque control, but is it a grade modifier? Is it like considered a risk factor when it comes to grading? No. So this smoking and diabetes is a great grade modifier risk factor, and because she's not smoking, the only thing she that is a modifier for her is her elevated HbA1c level. Okay, and last question is, why do you think number 2 and number 20 are hyper-erupted? What I mean by this is, if you look at this dude over here, the 1.7 in FDI, and this dude over here, the 3.5, do you see how it's hyper-erupted or supra-erupted? What causes that? What do you think? If you said A, you would be correct. It's because they don't have a teeth on the opposite arc, and because of that, it's going to naturally drift, or get erupted, supra-erupted, or hyper-erupted. Having a lesion, there's no indication that this person has a periapical lesion in the radiograph. Calculus does not make teeth hyper-erupt or supra-erupt. Unmet restorative needs, not the greatest answer. The best answer is A. Both have no opposing teeth.